Good afternoon. I'd like to thank all the organizers for inviting me, especially Roger and Gautam, who's my classmate. I would like to also take the opportunity to share the platform with the eminent personalities and doctors in this August gathering. Especially, I remember Professor Sukumaran Mukherjee was my external at North Bengal in 1989 when he took our medical examination. I'm sharing the platform with him, which is a huge honor for me. Staying with the concept of gas, I would say, because I also have shared this in gastroenterology. My MD was in general medicine under Professor Goham Majumdar, but I was also working with Dr. Professor Chaudhary at that time, and my topic was irritable bowel syndrome. That was perhaps the introduction to psychiatry. As we've heard, we had short notes in MBBS and not much in MD either. And I realized there was a lot of interest in the gas troubling the Bengali population. My thesis was on irritable bowel syndrome, looking at constipation versus diarrhea presentation of these patients. And I did anorectal manometric studies, and also we looked at the brain gut axis and looked at different aspects of psychosomatic presentation. But that was my introduction to psychiatry, nothing much. And I went to the UK in 1997 just to take a lab exam and started getting to work very closely with allied health professionals, including psychiatrists with whom I hadn't worked much in India. And I was fortunate to get into the rotation in Oxford for geriatric medicine, and then I've been a consultant in geriatric medicine in Reading for the last 15 years. So what is geriatric medicine? As Ranjan has already highlighted, it's the management of older people, acute medicine and chronic disease management in older people. And we've been hearing about functional disorders like schizophrenia and suicide, but a large proportion of these older people have dementia. And that's very important when these patients go into the hospital. And we have been working very closely with the psychiatrists in Reading, in UK, where I work. So we cover a large population, about 500,000, and it's a large district general hospital. We have more than 800 beds, but as we know, 2/3 of the NHS hospitals in the UK have older people above the age of 65. And what do they bring with them? A large proportion of comorbidities, lots of diseases, lots of drugs, all interacting between each other and presenting in acute medicine. So I work in A&E, I work in the acute medicine unit, I also work on a ward. We have a large proportion of hip fractures. In the last 15 years, I have developed the hip fracture service in the UK, in our hospital. And hip fractures are admitted under physicians. It might be news to you, but surgeons are just allowed to operate. Similarly, with surgical intervention in older people, we have a Professor Gosling who works with the surgeons, and the surgeons operate, and we work together collaboratively. Older people's health care is very important in terms of managing their delirium and dementia. So the government in the UK brought out an important document about dementia in 2009, and most hospitals in the UK were asked to start looking at their services, how we can work together. And I was involved as clinical lead at that time in Reading to develop the older people's mental health liaison service. And I'm very proud to say that it's working very well. I cannot imagine doing a ward round or my day-to-day work without liaising with one of your colleagues. Psychiatry is bread and butter of a geriatric consultant because older people have mental health problems. It's not just depression or functional disorders. They are demented, there are lots of drugs which we need to tease out amongst each other. We share a lot of commonality between the patient population, and we have developed quite a number of things which I would like to share with you on the platform. We have developed dementia care, how one should respect and look after a patient with dementia who's presented with perhaps a fall and just an infection in the urine, or maybe just a patch of pneumonia, but how it involves into their walking, into their discharge planning, and also into their making decisions about end of life should they not survive. Because these patients cannot make responsible decisions, and there's capacity assessment for these patients which need to be made quite importantly with the family members. So dementia, delirium, psychosis, all this is part of general medicine and geriatric medicine. I think all over the world there are different names probably, there are different aspects of looking into how to improve services for all of these people. And now I am, as the training program director for geriatrics in Oxford region, I work very closely with the deaneries and the Royal Colleges to look at the curriculum. And one of the biggest chunks of medicine is to provide geriatric services in psychiatric hospitals also, and vice versa. All my trainees, we have 30 trainees in Oxford, they have to go through an assessment for dementia, delirium, and there's a whole lot of curriculum which needs to be delivered. And how do we do it? We work closely with the psychogeriatricians in Berkshire and in Oxford to make sure that they understand polypharmacy. The other important thing is psychiatrists also need physicians to make sure that drugs and ECG changes and other things needs to be understood quite well. And I was fortunate enough to be involved in a document by the Royal College of Psychiatry which was published last couple of months ago on looking at the physical aspect of mental health patients. Because ECG changes, hyponatremia, perhaps hypoxia, tachycardia, these patients come back to our hospital. So we are trying to develop a service where geriatricians go into psychiatric hospitals and make sure those patients stay in those wards rather than come back into the acute hospital. So there's quite a lot of commonality between psychiatry and geriatrics. And I think one of the major things would be to work collaboratively to improve the care of the patients. In 2016, both of them had come to the UK and we had a big attachment, a big meeting with the Royal College of Psychiatrists and the British Geriatric Society to try and see if we can do collaborative working in India and to have workshops. I don't think there's been much progress and we would like to make that an opportunity to try and develop the services here. And I understand there's a Facebook page now where we can approach mentorship. Thank you for giving me this opportunity.
মনে দুশ্চিন্তার কালো মেঘ দুকুল যখন ছাপায়, বুকে চাপা পাথর দেখো থাকে আলোর আশায়।
দুশ্চিন্তার কালো মেঘ দুকুল যখন ছাপায়, বুকে চাপা পাথর দেখো থাকে আলোর আশায়। মনে দুশ্চিন্তার কালো মেঘ দুকুল যখন ছাপায়, বুকে চাপা পাথর দেখো থাকে আলোর আশায়। রোদ্দুর হতে চাওয়া স্বপ্নে কোনো অলিক মায়ায়, সুইসাইড নোট থাকে যত্নে বিরহে দুঃখে হতাশায়। গান বাঁধি ছুটে চলার দিনে যান্ত্রিক শহুরে ব্যস্ততায়, ডুবে থাকা নেশায় ঋণে সীমাহীন লোভ মদ মত্ততায়। গান বাঁধি ছুটে চলার দিনে যান্ত্রিক শহুরে ব্যস্ততায়, ডুবে থাকা নেশায় ঋণে সীমাহীন লোভ মদ মত্ততায়। 40 সেকেন্ডে এই দুনিয়ায় ঝরে যায় একটি প্রাণ, আত্মহত্যা শুধু আটকানো যায় বাঁধিতাই এই সুরতান। নয় ভীরুকা পুরুষ তারা আপন তোমার আমার, কুসংস্কার করে আসুক নতুন দিনের ভোর আবার নয় ভীরুকা পুরুষ তারা আপন তোমার আমার কুসংস্কার করে দূর আসুক নতুন দিনের ভোর আবার When the heart is your blue, when there is a dark, feel the pain in your heart and wait for some spark. When the heart is your blue, when there is a dark, feel the pain in your heart and wait for some spark. Dreams that turns into flashing light in your lonely midnight. Suicide note on the table, wake up, it's only preventable. Composing song in our busy life, cacophony becomes the only tune. Gambling, debts and addiction, failure, breakups and misfortune. Composing song in our busy life, cacophony becomes the only tune. Gambling, debts and addiction, failure, breakups and misfortune. 42nd in this world, someone committing suicide. Stigma, prejudice, story untold. Please don't blame them, curse on scold. Not wicked, loser or cowards, all of them are very own. The dusk will pass in due course, new hope will bring the new dawn. Not wicked, loser or coward, all of them are very own. The dusk will pass in due course, new hope will bring the new dawn.
The dusk will pass in due course, new hopes will bring the new dawn. নয় ভীরু কাপুরুষ তারা আপন তোমার আমার কুসংস্কার করে দূর আসুক নতুন দিনের ভোর আবার কুসংস্কার করে দূর আসুক নতুন দিনের ভোর আবার